is the treatment that is initiated before the surgical procedure or the pain stimulus is given. So you can also call it as preventive analgesia. What is the main mechanism? It prevents the when we just now discussed about the sensitization, that is repeated stimulus causing increased response from the nerve endings causing persistent pain. So that sensitization is blocked by giving the preemptive analgesia. So transmission of pain signals evoked by tissue damage leads to sensitization of peripheral and central pain pathways. So preventive analgesia has the potential to reduce this sensitization. That is the main mechanism that we have to understand. So which condition is suited for preventive analgesia and why? Preventive analgesia would apply to situations of elective surgery. So patients should not have any pain before you start the surgery. For example, in elective inguinal hernia, an elective incisional hernia, or an elective thyroid surgery. So such procedures where there is no previous pain sensation, that is where the preemptive analgesia will work well. And in this situation, it is possible to control the series of events and possible to deliver effective analgesia before the start of the surgery. On the contrary, a patient with a fracture who has already been suffering from the pain which has inflicted because of the injury, their preventive analgesia will not work because already he is suffering the pain. So if you see in these pictures, surgical and post-surgical afferent input, that is the duration of surgery, this is the nociceptor input. So there is no preemptive analgesia given here. And the stimulus has been maximum. So you see the hypersensitivity happening in a very, very large way. Then post-surgical analgesia, surgery is completed here and analgesia is administered at this time. And the nociception input is still there. So hypersensitivity is divided into two blocks. So analgesia temporarily reduces the pain, but later on hypersensitivity happens again. The third condition, pre-surgical analgesia. Analgesia is administered before the start of the procedure itself. The A stands for analgesia. Here no analgesia is given, so the pain is maximum. Here the analgesia is given after the painful stimulus has been initiated. So then still the pain is high. Whereas once you give the analgesia before the start of the procedure, start of the surgery, the nociception that is felt is much less and the hypersensitivity happens very, very minimally late. And pre-surgical and post-surgical analgesia, so you give preemptive and also supplement analgesia throughout the intraoperative period, then the hypersensitivity is practically nil. Patients are very, very comfortable. So a combination of preemptive surgical analgesia given before the onset of stimulus and quietening the pain intraoperatively. This is what we routinely do nowadays in our, you start with 1 or 2 micrograms of fentanyl as soon as you institute an IV access, and then intraoperatively either time based or the stimulus based, you keep on supplementing analgesia and you get a very good response in the post-op. Patient is very comfortable. He opens the eyes and tells you that, thank you doctor, I am not having any pain. They are able to respond in that way. So the idea of knowing about preemptive analgesia is it should be administered before the painful stimulus. And the way in which you can deal with this by various mechanisms, what you mentioned here, how the various modalities of providing the preemptive analgesia. At the site of trauma, you can use local anesthetic inflammation, can give anti-inflammatory drugs like your NSAIDs even before the start of the trauma, or you can give nerve blocks or regional epidural or local anesthetic block. So local anesthetics play a very important role in providing preemptive analgesia. So by giving a block or facial plane block or epidural or intrathecal, you can definitely block. And at the level of dorsal root ganglion, you can give preemptive analgesia with opioid alpha-2 agonist. And at the central level, you can use opioids or alpha blockers. So these pictures will help you to remember the various modalities with which you can block this sensation. Now, why preemptive analgesia is used? To reduce acute pain by blocking the pain signals before they are initiated, and it can also prevent chronic pain prevention. So, by minimizing the sensitization and acute pain, preemptive analgesia can reduce the development of chronic pain. So, chronic post-surgical pain, one of the reasons is inadequate intraoperative analgesia, that you have to remember. And the agents and techniques used are local anesthetic blocks, NSAIDs, opioids, and the practical points in use of preemptive analgesia are you should use a multimodal approach. So effective preemptive can be a combination of different pain relief like local anesthetic NSAID, and specific drugs and timing of administration can vary depending upon patient's condition and the type of surgery. Now going to the Cpsp, it is defined by Acker and Davis. They were the people who first gave this terminology of chronic post-surgical pain. And they said that specific criteria should be fulfilled before you call a condition as the post-surgical. It should develop after surgical procedure, number one. Number two, it should be at least the pain is at least what is that? More than 3 months, and other causes of pain should have been excluded, and the possibility of a pre-existing condition also to be excluded. And updated definition is it's a persisting pain for at least 3 months after surgery, which was not present before surgery. That is very, very important. At the particular site where they operated, there should not have been any pain, or that had a different characteristic or increased intensity for preoperative pain and localized to the surgical site or referred area, and other possible causes of pain were excluded, like cancer recurrence or infection. So this is the current definition of should have occurred after surgery and be lasting more than 3 months. And the risk factors, type and approach of surgery, patient factors like female gender, being young adult, gentle, genetic predisposition, and psychosocial factors, and pre-existing patient conditions like pain present preoperatively or any persisting painful conditions, and perioperative factors, longer the duration of surgery and the extent of nerve damage intraoperatively, all can contribute to Cpsp, and correlate with the messenger RNA expression of the signal transcription genes representing genetic influence on Cpsp. So patients who have genetically been prone for more pain, they found that messenger RNA expression in signal transduction is that is at the conversion of painful stimulus into surgical stimulus is much more aggressive in these patients, and that is why it persists for a long time. And what are the methods of preventing Cpsp? It's the modification of surgical technique. So minimize the tissue damage, minimize the dissection, minimize the retraction, etc. Minimally invasive surgery and less extensive surgery. Treatment of preoperative pain with good pain control, and modification of anesthetic technique by employing regional anesthesia wherever possible with or wound and infiltration, etc. Then pharmacological treatment in the form of gabapentin, pregabalin, NMDA agonist, lidocaine, NSAIDs, acetaminophen, and opioids. Psychological intervention like preoperative counseling and then talking to the patient and getting their confidence. All these things go a long way. And which surgeries are likely to cause most pain? Hernia surgery, chest surgery, amputation, vasectomy, joint replacement surgery, joint replacement surgery, spinal surgery for back pain, breast surgery for cancer treatment, and these are the common surgeries which can result in Cpsp. And step-by-step approach for the prevention of chronic is does the patient have preoperative pain? First, first assess whether they are female gender, young adult or old people. What is their psychosocial factor? All this has to be preoperatively assessed. Does the patient have preoperative pain? Does it have any patient-related pain that has to be treated likely before the surgery? Is the surgery a high risk for developing Cpsp? Then provide alternatives or less extensive surgery. Is acute postoperative pain adequately controlled? That is another important step in preventing chronic post-surgical pain. And the postoperative pain persisting longer than usual, identify the cause and try to treat. So if you go using this approach, then you can treat most of them. And treated by identifying the etiology through history taking and physical examination. You can do pharmacotherapy. You can use various drugs, and lidocaine patches are now more effective for neuropathic pain. Nitroglycerin transdermal patch also used for chronic post-orthotomy pain. Pain interventions like nerve block, nerve ablation, and neuromodulation. Surgical management, resection of neuroma and autologous fat graft for painful scars are also being tried. And lifestyle modification like physical therapy, massage therapy, acupuncture, and don't ask the patient to rest and wait for a long time. Avoid rest and activity limitation. Ask them to be as mobile as possible so that the pain will be supposed to come down much more. And psychological interventions and cognitive behavioral therapy are also used for this particular treatment. Okay.
Yes, sir.